All right, guys, welcome to a brand new show from Mahajan Medical Center. We are very excited. We got fantastic guests today, and we're going to talk about why it's so important to see your primary care in their offices instead of running to the hospitals, emergency rooms, and other settings. You will find out why. We have a good-looking home health nurse who's our patient, Deb, and she's going to tell us her experience, what happened when she got dehydrated, and instead of running to the hospital's emergency room, and she was taken care of much more efficiently in the office. For folks who don't know me, my name is Dr. Ranjan Mahajan, and I'm a practicing internist in Largo. And I practice here with 5 providers, and we have a practice in Pinellas County for 26 years. And we do periodic webcasts to help our patients make better decisions, education, and healthcare wise. So I'm going to invite first my lead MA, Jen. So Jen, why don't you come over and introduce yourself, and we'll talk about what we set up at Mahajan Medical Center recently. Have a seat here. Here is Jen.
Hello, everyone. My name is Jen, and I'm one of the lead MAs here. I also do our care coordination program in CCM. And today, I just want to explain that we have a new program in our office. It's IV hydration, and it's really great because the patient can sit and relax in our nice, comfortable chair and get the hydration that they may need. This is really good if the patients are feeling dehydrated or nauseous and vomiting or having diarrhea. And instead of going to the hospital and waiting many hours in a cold room, we can offer IV hydration here in a nice warm setting with a very comfortable chair.
I think that's a great introduction, Jen. Jen also does something phenomenal for our patients. She's a lead case manager for all our patients who end up in the hospitals or nursing homes, and when they get discharged, we wanted to make sure that they don't fall through the cracks with their medications, or if they need to follow up on any of the lab tests, then she makes sure they have a good transition and they don't end up in the hospitals again. So Jen does a phenomenal job with transition of care, post-hospitalization, post-nursing homes. So if you have not met Jen, and you should say hello to her. And also she run a great program called Chronic Care Management. Jen, you want to talk a little bit about chronic care management?
Yeah, so the chronic care management we offer here is just to help you get more in touch with diabetes and how to help control those. I have different diet programs and lifestyle changes that we can talk about. And I really feel that it helps patients because it gives them a personal touch to help them go through this difficult time. And also we do other things like high blood pressure, and that's just, along with diet and lifestyle changes, basically just trying to keep hospitalizations down and getting a better quality of life.
Great point, Jen. I want to introduce the concept of 3 C's, and that will help you understand why we put together that program. Instead, the 3 C's, the first C stand for continuum. So if you're thinking about the care in this great country, United States, it's very splintered. Traditionally, you go for your blood pressure monitoring and treatment with your cardiologist, let's say, and then they prescribe you medication, and then you come to your primary care office and you don't know what the medication is. And they prescribe you something else. Now you have 2 medications for the same condition. So if you use primary care practices for most of your chronic care ailments, as Jen was alluding to, for example, high blood pressure, diabetes, COPD, congestive heart failure, weight management, you will have better health outcomes because the continuum, again, the C for continuum, the continuity of care. And same thing applies if you have a practice like ours, which, for example, I go to 2 hospitals in Modern Plant, downtown Clearwater, and the HCA hospitals in Largo Med. So I know what's going on in the hospital. So when you get discharged, I can take care of you in the office. So the transition is much more less splintered versus, if you see a hospitalist and then, we have to go through reams of records. So the C for continuum is using your primary care more effectively if you come to the office first. So if you call us first, if you have a UTI, instead of going to urgent care, we know what antibiotics to prescribe. So that leads to the second C, which is comfort. The comfort is, Jen, the front desk, me or the other nurse practitioner or Dr. Meera, the providers in our practice, and it's comfortable versus, you go to urgent care or emergency room for that UTI, or in Deb's case, dehydration. Then you have to fill up reams of records, and it's 4 hours wait, and you get one antibiotics, and you said, see your doctor. So you're better off, calling us first. And the good thing is our office manager, Deb, has set up a program where we keep spots open, what we call an open schedule for all our patients to walk in, and we'll see you. Maybe there's a wait for half an hour, 45 minutes, or maybe none, depending on how the day is going. But at least you have the comfort. And the third C is consistency. What I mean by that is, if you look at, let's say, you tried sulfa medication. I'm continuing with the example of UTI. You're not really allergic, but you develop thrush, oral fungus, or in women, some women have a tendency to develop candida in their vagina. And we know that because we have notes in our chart. But if you go to the urgent care or ED, they don't know that. They will prescribe sulfa because that's a good drug for UTI. And, you can avoid all that hassle. So that's the third C, is consistency, that there's comfort, there's consistency, and there's continuum if coming to your primary care practices. The last is S. I'll introduce to the S. I think that's important, which is safety. You probably heard of a poor nurse who was giving Versed for a MRI recently in the news, and poor thing used the EMR in the hospital, and in came Vercurium, which is a muscle relaxer, and the patient died, unfortunately, because of that, because the hospitals have access to much more potent drugs. So the risk of the errors, unfortunately, is higher in those settings. And not that the hospitals mean to, but they have access to those bigger tools, which luckily in primary care practices we don't. So less risk of those kind of major errors. Errors can happen anywhere. I'm not saying the hospitals are more prone, but it's just the errors will be a little bit more magnified in terms of if something unfortunate like that happens. The other piece of safety is the multi-drug resistance bugs. If you go in the hospitals, you want to talk about that?
Yeah, sure. So as you know, when you're in the hospital, you're around other people that are sick, and there's a chance that you may catch something that they have, or some hospitals just have diseases and bacteria that you can catch. When coming to our office, we're a much smaller office. We don't really see those sickly patients, and you can just be assured that you are not going to catch any bugs from the office, coming to the office.
Especially in this pandemic, the COVID pandemic, everyone is worried about getting Omicron or the Omicron variant now. And in a bigger setting, when you're exposed to other sicker patients, like in ED settings, which are open platform, it's very hard to contain those despite the best efforts, having sicker, patient one side, but still the air is, very common what you inhale. So, and then the drug-resistant bugs are more prevalent in inpatient setting, for example, MRSA or, VRE, and which, if God forbid you get it in your wounds, or which we can manage, and we'll have Kate talk about wound care in a minute, which we can manage in the office much more safely. So the risk of getting those multi-drug resistant infection is much less in a smaller office setting. So now we talked about wound care. Do you have anything, other services you want to highlight before I get Kate up here?
Well, you know that we do blood draws in the office, and all of our girls are very good at them. And so you have that, so not have to worry about that. When you're in the hospital, sometimes you get stuck multiple times, and we don't have that experience here. So you have to be happy about that. And we also do some in-office tests, like we can do your urine dipstick, and we can get results to the doctor right away to see if you need to be treated for that. We can do some in-office tests as influenza and strep, and those are rapid tests, so we get those results back within the 5 minutes. And then, of course, that can be taken right to the doctor, and you could be treated right away with that. And we have breathing treatments. So if you're not feeling well and you're having trouble breathing, we can give you a nebulizer treatment right in the office, and that's really great.
So I think that's a great point you bring, Jen, that the testing which we can do in the ambulatory or office setting prevents hospitalization. For example, you gave an example of breathing treatment. So if someone has acute exacerbation of bronchitis, instead of running to the hospital, we can give the nebulizer treatment right here. We can give the nebulizer treatment right here in the office, along with the oxygen if they need it. Mm-hmm. And we can give the steroid injection or antibiotic injection if needed. So then, we can bring them next day. So that's the other piece of continuum or continuity, which I was mentioning earlier, the 3 C's, that we can see them next day. And, if they're not better, we can repeat the nebulizer treatment, taking the example of acute bronchitis. Next day, we can give the shots again and monitor them. And now we have the IV infusion. So if you have diarrhea or dehydration, we can give the IV fluids here. So all those things, were not as prevalent in the previous model, where you start thinking, let me call 911. Instead of doing that, if you think, of course, if it's an emergency, the hospitals definitely have a role to play. I'm not debating that fact. If you have a, God forbid, stroke going on or a heart attack going on, the office is not a place to come. But if you have something other than that, which you think is not a medical emergency, call us first. And that's the logo we have all over our office, that you call us first instead of calling 911. And I'll bring Jenny, who's our insurance guru, in a minute, and she will talk about the financial implication, which is another C, the cost effectiveness of this whole care. We can provide better in the office, safer in the office, and more cost effective way. Jen, let's introduce Kate. Kate, you want to come over? I can give the microphone to Kate. So Kate, let her get settled down. Okay, good. Kate, you want to introduce yourself? She's a MA, which has been a beautiful addition to our medical assistant team, and she is doing a phenomenal job with our patients. And she has a lot of experience with wound care and blood draws. And you tell us more about yourself.
Yes, hello everyone. My name is Kate. I'm very excited to be a part of Dr. Mahajan's practice. Like he just mentioned, I am bringing a background of the wound care that I used to work for, and I do have pretty wide knowledge about it. We developed pretty wide customer service right now here for our patients about the wound care. It's preventively for infections. We know a lot about our patients, means the medical records actually, like diabetes, like any type of blood thinners that you take. So it's very good to first contact us before you will go to emergency room.
Great point, Kate. And Kate and Jen bring a wealth of experience. They all been in the industry for a long time and helping the patients in various capacities. So we're very fortunate to have 2 very senior medical assistants, helping Mahajan Medical Center with their patient care. So yes, so call us first, and I'll introduce our star of the show, Debbie. Debbie, you want to come? Kate, you want to step back for a minute? You want to hold this? So Debbie, come on in, come on. All right, so do you want to introduce yourself, Debbie? You know, how long we've known each other?
Yes, my name is Deborah, and I have been with Dr. Mahajan since he was a baby. No, we met at one of the facilities. I was working there as a nurse, and he was the doctor, and I really liked him. He's treated my whole family. I think we're on 3 generations now of him treating my family.
We took care of your mother, we took care of your daughter, and we didn't take care of your granddaughter yet.
Not yet.
Your mother was just like you. She was amazing. You know.
Thank you.
So the reason we brought Debbie in today's show is she has a background as a nurse, so she knows all sides of healthcare, the office setting, the outpatient, ambulatory, like urgent care settings, the emergency room setting, the hospital setting. And tell us your experience, what happened, and you used us recently for something different, which you not used us before from Mahajan Medical Center.
Well, a couple of weeks ago, I unfortunately got the stomach flu. And I thought, oh, it'll be gone in 24 hours. Well, in 48 hours, it was still there. So by the 3rd day, I thought, I think I better call. So I called and explained my situation, and they put me right through, and they said, you can do a video visit. And Jackie, within, I think it was less than an hour, I was on the phone with Jackie doing a video visit, and she said, why don't you come in and get some IV fluids? Well, I had no idea that Dr. Mahajan's office was doing fluids, and because I thought I might have to go to the hospital. When I got here, I went right in. They had everything ready. The girls and the personnel, the staff that put the IV in, they had the hydration hanging ready for me to go. Very comfortable chair. Everyone came back in and checked on me to make sure that I was doing okay. And I went home, and by the time I got home, I was feeling better, but definitely within a few hours, I was almost back to normal. So I really, really thank you for doing this. It's a real special program. And as a nurse, we have to send a lot of patients to the hospital for hydration. So, it'll be nice to know that Dr. Mahajan's patients will be able to recommend that they come to his office.
Thank you, Deborah. That was very kind of you. And, I think we were debating about whether to add something like this to our practice, and I'm glad we did. Another instance come to my mind recently. We saw a patient with swelling in the leg, and I was suspicious that there could be blood clot in the legs. In olden days, we used to send those patients to the emergency rooms if we suspect blood clots in the legs, but now with the availability of, outpatient radiology services giving us slots on the same day for the venous Doppler, we were able to get the report on the same day, and this gentleman did have blood clot in the leg. So we brought him back to the office, and we gave him the samples for the blood thinners, and he did beautifully. And, if you compare that, and I'll bring Jenny in a minute, a similar scenario, going to the emergency room, waiting 4 hours, filling all the paperwork, waiting for your turn, getting exposed to all the other sicker patients there, and getting a Doppler. Now, most of the ERs feel more comfortable once they find something like that to admit the patient. And there is a cost implication, which we're going to talk to Jen about in this scenario. And then, so you're there for a couple of days, and you can achieve the same outcomes now with, if you're stable. Of course, you're unstable, then this scenario does not pan out. But if you're stable and the blood clot has not moved to the lung, these are all could be managed in a outpatient settings like our office. So do you have anything else to add, Deborah?
I would like to say one thing.
Sure.
I remember you were feeling a little nauseous after leaving and you got a shot too, right?
I did. Actually, I really expected to just come in and get the shot. And then when they said fluids, I was like, oh yeah, that's great. So yes, I did. I did get a shot of, I think it was Finnegan.
Yes.
And felt much better. So I'm really thankful for this service. It's great. And I plan on, kind of letting our patients know as well that Dr. Mahajan's services, IVs, DVTs, and that sort of thing. It would be so much better that we have a place to send our patients as well, rather than right to the ER.
Great. Thank you, Deborah. Let's bring Jenny in. Give the microphone to Jenny, if you don't mind, Deborah. Jenny is a special Mahajan Medical Center extension.
Thanks. I guess so at this point. It's been a few years.
So Jenny has been with us for 4 years now, you would say?
Yeah, COVID kind of
Yeah.
blurs things.
Right.
Four?
Four?
Five?
Five,
Four?
maybe five. So yeah, around 5 years. So what Jenny does for us is she helps our patients who are turning 65, and she helps them guide in the right direction, whether they are a candidate for a plan like Humana, or if they have other benefits, something else suits them. So Jenny is phenomenal. She has 17, 18 years experience.
Yes. With Medicare.
Yes.
She started when she was in kindergarten. So Jenny, in the scenario I described with the DVT, let's say now they came to the office and they went to the imaging center, their cost is zero if they are Humana or on a value-based plan, correct?
Yeah, I mean, I actually had a DVT years back.
Oh, I'm sorry.
So I can attest to this too.
So tell us your experience before the ambulatory started doing what we
Right.
did.
So this was 15 years ago,
Wow.
actually, that I had mine. And this was before Xarelto
Right.
and Eliquis and all
Right.
that. But it was, you were sent to the ER. They did the Doppler imaging, which, by the way, is the same imaging that you can have done. It's the same exact test they do at any other imaging place.
Outpatient, yes.
It's just 10 times as much or more actually more than that at the emergency room. And then, I was in the hospital for days, and it's not fun. So I can't imagine, I really just wanted to go home. But not only that, the cost of it was completely crazy when I looked at just how much things are charged. And the thing is, I realized that, I pulled up a lot of information just because what I always tell people, including my friends, my family, my mother, hopefully she's not watching this on Facebook. Hi, Mom. But I explained to them, sometimes even if your copay is very low, it's okay if I go to the emergency room and I'm admitted, it's waived, or if I'm treated or released, it's still only, $90 or whatever it might be. Well, in the end, we really all end up paying for it. And that's what I try to explain to my friends, family, everybody. Is it okay if I explain a little more?
Sure, go ahead.
Because Dr. Mahajan and I were discussing this the other day.
That's how we brainstormed this session. Jenny was saying, hey, it would be great if we can educate our patients why it's important to call the primary care first. And I said, that sounds good. And that's how, we started talking among our team and we came up with the show. So yes, it was Jenny's idea. Give her copyright for that.
Oh, well, thanks. Just from a comfort standpoint, if you're not dying and you go to the emergency room, you said 4 hours wait, that's being very nice, because if you go to the emergency room for something like a sore throat or a stomach ache, you're going to be there a long time and probably get released and with nothing, with maybe a shot of whatever you guys can do here. By the way, that hydration thing sounds pretty nice. Maybe like after a rough night out. Just kidding. I don't go out anymore anyway, but it might have been useful.
Yeah.
So maybe you should open up that oxygen bar. So. But and I have family and friends that are guilty of this. They went to the emergency room because I had a family member who their fever was 101.5. Well, yeah, that's a fever. Call your primary. Don't go to the emergency room. Okay. There's no reason to, again, from a financial perspective, here's how much it ends up costing. This is actually a study done by United Healthcare, and this was 2018 data. So it's before COVID. Figure that's important. There were 27 million hospital emergency room, emergency department visits for 2018. So 27 million.
Wow.
Any guess on how many of them were preventable, meaning, and that doesn't count someone who went in for chest pains and didn't have a heart attack, meaning preventable as in they should have gone somewhere else. How many? Anybody? All right, I'll just tell you. 18 million of those were preventable.
Wow.
That's more than 50%.
Yes.
Wow.
And that included, it said 10 common primary care treatable conditions. Bronchitis, cough, dizziness, flu, headache, low back pain, nausea, sore throat, strep throat, and upper respiratory infection. So that equaled $32 billion.
Wow.
That could have been potentially saved. And again, I think with the copays, or even someone that has a Medicare with a Medigap or Medicare supplement, you might not pay anything when you go, but in the end, you are going to pay for it because the premiums for insurance are based on claims.
Yeah.
Medicare, how much Medicare costs. I had a lot of people upset about, Medicare Part B going up. Again, these things are based on usage. So if you sort of abuse that privilege which is a wonderful thing that we have, we've got a great healthcare system as far as treatment and care. But if you kind of abuse it, it does cost you more. You do pay for it. So the cost of healthcare has just skyrocketed. And I think, that's one of the reasons why. Just to give you an idea, this is the same study that was done, again, from United Healthcare. And I work for Humana, not United, but this is just public information. Average cost for primary care treatable conditions in 2018. So if you go to the physician's office, just the average overall cost was $167. Urgent care cost, $193. At the hospital, it's $2,032.
Wow.
Big difference.
I mean, that's just astronomical. So, again, if you want to see, insurance premiums stay low. And again, that's, even though you may not have a copay or you may have a very little copay, you do pay for it in the end. Okay. That's just kind of how it works.
Yeah, that's amazing. I'm glad you brought this study. I was looking at it too, and I was amazed that $2,000 some odd for treating UTI or acute pharyngitis. I don't know how long it's going to be sustainable if we all does not make a conscious effort that unless it's a true emergency, we use those resources. And also, you think about it, if you have a patient with ST elevation MI, which is a true emergency, heart attack, where they need to go in and open up the artery of the heart, and you have a 5 patient with UTI, acute pharyngitis, think about how much slower care that emergency will get, because unless they came directly, knowing it's a heart attack, sometimes it's subtle. And if you have 4 or 5 patients for the ED team to triage, which could be handled in doctor's offices, then the true emergencies get a little bit more delayed and pushed back. So not only the cost is higher for those acute pharyngitis or sore throats, UTIs, cellulitis of the skin, which are easily treatable outpatient, or pink eye, you also making the true emergencies take longer to get care. So that's another factor we all need to consider. And also think it this way, the number of younger generation are having less and less children. So the care, the cost, or the utilization of healthcare is with this older population. So if the older population does not think about, picking a cost-effective and a safe and comfortable setting like offices versus ED, there won't be enough money left 10 years from now because there's not much money coming from the bottom because there's not enough younger kids contributing to the Social Security and Medicare funds. So it is everyone's responsibility, as Jenny pointed out, to be more cost effective, more vigilant in terms of the care, even if most of the people have higher co-payments, let's say, $100, $150 going to the emergency room. And then per day, there's a charge for being in the hospital till you make the maximum. And then, you're okay. But, so it does not, for most of the people, is not free unless you're dual eligible or, people with less means, then it could be freer. But then you think about not being in an appropriate setting, getting exposed to the medical errors. And if you end up in a hospital for longer stay, you get more deconditioned because you're in the bed too long, you don't move around as much. B, you get despondent because nonstop, checking the vitals, not getting adequate sleep, that affects your immune system and outcomes too. So the hospital should be for sicker patients, acute care, get in and out, not for something which can be treated in the office. So do you have another point you want to bring, Jenny, on that?
Well, you mentioned just imaging, for example, and there was an example here of he wasn't on Medicare, but a younger guy that went to, he had some stomach issues, I guess. They did a CT scan, which used to be called a CAT scan. Now it's CT. Did they change it?
No, it's just become more fancy. The CT looks
CT
fancy.
Scan.
Yeah.
So he actually had, so he went to his doctor. They did a CT scan at a freestanding imaging facility. And I think he only had to pay, he had a deductible, but he had to pay $236. So everything came back okay. Flash forward a few weeks, and I guess he was still having symptoms. So instead of calling his primary, maybe for a follow-up or a different type of test, he went to the emergency room, and they send you home, and then you get a fun bill in the mail. And his total bill was included one for same test, same machine. It was $8,800.
Wow.
And then some things I didn't know too, that there was another article published by actually someone at NPR. I try to get creditable sources. Always check your sources when you're reading information, because just because it's on the internet doesn't mean it's true. I remind my husband of this. So NPR, creditable source. But, again, just saying how the cost difference between those two things. But not only that, there's I didn't realize there's emergency room. Even if you walk in and they don't even see you for anything and they just give you an ice pack, there's a facility, just charge for walking in the door. Or medication. People always joke, I guess it's really not that funny, but like a Tylenol at the hospital versus
$10.
I've heard that. Yeah.
More than that. There was an example here of a lady getting eye drops, and on her bill, and they didn't give her the prescription. They just put the eye drops in, and the charge for just putting the eye drops in was like $225. But you could actually you could buy the prescription, like a month's supply, for between $15 and $50. And that's just the cash price.
Well, on the same article which you're talking about, NPR, there was a guy whose kid had a arm fracture or something, and they went to a ED. It was super busy, so they just registered, didn't even get the x-ray, then saw the ER physician. They walked out, and they next day went to their primary care and got the x-ray done outpatient, and then they got the splint. But just getting in, they got a bill for $2,000, just to register and say, hey, we are here. So, the cost of care in the hospitals and the ED is super expensive. You can't blame them. It is, they have to have X amount of RNs, X amount of pharmacists, facilities and regulations. So it becomes expensive, so it's better if you think about that, and then, out of network. So a lot of people don't realize you're an insurance guru, out of network is hopefully with the new law kicking in, it should settle down. But, the folks who don't know, the hospitals could be in network, but the ED physician group may not be in network. So what that means is, yeah, you did your research and, you have a sore throat and you went to X hospital and they're on your network, but then the ED physicians are not in network. So they can give you whatever they feel like. There is no limit on what they can bill you and you're obligated to pay. So those complexities become even more horrendous when you go to more complex settings like hospitals. When you come to a office setting, it's straightforward. I take Humana, we take Humana, there is no extra billing. So you want to comment on that?
Yeah, I mean, I think it's, of course, the emergency has its place.
Sure.
If somebody's having a heart attack or symptoms of a stroke, or, if you're in a car accident, you need to go somewhere by ambulance. Yeah, I mean, that's what it's for. I just feel like in this country, it's almost become a routine thing, like, oh, just go to the emergency room. And I think that's sort of where things get, hazy. But, again, cough, sore throat, stomach ache, stuff like this. This is something that if you don't have a primary care, because I have talked to people and they're like, well, my primary won't see me. They told me to go to the emergency room. Like, really? I mean, they won't see you. I'm coughing. They don't want me coming in. I mean, really, if you need a primary who will, provide you that. I mean, not only that, but wouldn't you rather be somewhere where the people there, the staff? I mean, the last thing I would want to do, to me personally, and I've had my share of issues, obviously, is go to a hospital. I don't know anybody. I feel dumb if it ends up being nothing, which is not a reason to not go. But I mean, if I can go to a physician's office and they'll see me the same day, absolutely, absolutely, that's the place.
You brought a good point in the pandemic era, Jenny, the cough and, not exposing other patients. Jen, you want to talk about telehealth?
Yes. Yeah. So we're offering telehealth visits, which is a great, for what he was just talking about. If you think you're sick and you're coughing and, you just don't feel like coming in or you don't want to get anyone else sick, that's a great option. The doctor can see you right on there. He can discuss care with you and give you proper treatment. And he can also call in prescriptions. It's just like a visit. You're in the office. And I think it's great. And what do you think?
Yeah, so, with the COVID, something good came in healthcare. But I think with everything shitty, there's something good comes. With COVID, we got telehealth, nothing else, and that got paid by insurance companies. Yeah. It was there before, the technology was there, everything was there, everyone had cameras, everyone had microphones. The only thing missing was the reimbursement. So the COVID brought reimbursement from insurance companies to the table, and hopefully it stays. They keep extending it, hopefully it stays. I think it has a wonderful role in something like what Jenny and Jen was pointing, infectious disease like cough, where you don't want to expose the staff and the other people, and which is very genuine. And you can do just a FaceTime or even phone or whatever, device you have at home, laptops, Surface Pros, whatever you have. And then you can be connected with the provider and, it's at comfort of your home. Mm-hmm. And then the prescriptions, and that, by the way, is another great thing of coming to doctors' offices is prescriptions. If you think about it, all your medications are there. When you're going to the hospital, it's very hard to remember you're taking 5 or 6 pills, and the provider in the ED does not have the advantage of having the list of those meds, and you forgot to write down what meds you take. But in the office setting, we know what meds you take. So if I'm prescribing you something, A, I have access to allergies. B, I can check the interactions with other medications. So that's another value-added service which a primary care office can provide and reduce the chances of giving you something and giving you some side effects. So just on the side note, for why you should come to the offices first for something minor or something which you're not sure, versus going to the emergency rooms and hospitals directly. Again, as Jenny said, it does not mean there is no role for the hospitals or nursing homes or emergency rooms, or there is a big role, surgeries, trauma, heart attacks, strokes. You can't deal with that in the office. But if you think it's not a medical emergency, and you can call the doctor's office, you will see a benefit, especially if you have a relationship with a primary care.
Go in early. Don't be one of those people who kind of waits. Oh, and then it's Saturday.
Yeah.
And then, oh no, this whatever issue is got worse. I feel like if you do have a sore throat, or if you've been vomiting, don't necessarily wait 3 days. Call your doctor right away.
Great point, Jenny. And
before it gets to the point where it's really bad.
right. Do you want to talk about extended hours, Jen, which we can accommodate people?
I did want to mention one thing though, too. If you're not sure, just call our office, because our staff's very educated and we can help you decide, should I go to the emergency room, or can we take care of this in the office?
That's a great point. And, we do have extended hours, in the morning for the people who work. They can come in the morning before they go to work. So,
Yeah, we open 7:30. So
Right.
we have nurse practitioners here and at 7:30, and they always have open schedules. So we can do that. And then we also have later hours, 5:30 for, after work if you can't make it before work. So I think that's always great.
Right. So, it's a mindset. You got to, as Jenny pointed out, we've been used to the mindset of, go to the emergency room for minor things. It's just a mindset change, go to the physician's office, primary care office, instead of going to the emergency room if you don't think it's a medical emergency. Of course, if it's a medical emergency, you're extremely short of breath, I don't want you to come to the office. It's just going to delay your care. That's not the intent of this talk. The intent of this talk is, as Jenny pointed out of 28 million visits, 18 millions were preventable. So those are the 18 millions we're talking about coming to doctors' offices instead of going to the emergency department. In terms of, healthcare being splintered, that you also have to think of that. When you go to the ER, and let's say I don't go there, let's say you go to Advent Health, which I don't go. Now, when you come back and follow up with me, we can get the records, but the records come in this thick pile. So having to review the records and figuring out what really happened, and a lot of time patients don't know, they said, hey, they said everything is fine, go home, but the record is this thick. It's very hard. So it's good to, if you decide that's a medical emergency, go where your provider goes. For example, I go to Mont Plan and Largo Med. That's another piece of information you should have in your mind. If you have a medical emergency, go to the places where your provider goes. Though, if we can avoid it, and that's where I want to touch a little bit before we end the show, is population health. I think the biggest role I see for primary care teams like Mahajan Medical Center is not to provide, when the things are broken, as Jenny was pointing to, not to come to me when you're about to die and say, do something. Come to me early on. Let's say, for example, in our office, we are big on helping patients quit smoking. We are big on education on chronic care like COPD, congestive heart failure, type 2 diabetes, type 1 diabetes. Why? So I'll give you an example. We have a patient, who's been coming to our practice for many years, has been a smoker, heavy smoker, and I've been telling him for at least 10, 15 years, here's Chantix, here is patches, here is Quit Florida, free resources, please quit. We saw him about a month ago, and he has a big lump up here. Now you're talking something which could be prevented. And that's where the primary care shine. If he has listened, and I know it's hard, it's easy said than done to quit smoking, but if we provide you the tools, population health is where, a primary care can make a big difference, bringing your cholesterol down, helping you keep your sugars tight, more lifestyle changes, which we are big on, exercising, eating better. All those things, in my opinion, are more important, more critical. If you think about the model we have in the United States, it's mostly acute care. And we are phenomenal, as Jenny said, in those, for example, putting stents or doing transplants and those kind of things. The model needs to shift more towards preventive care, more towards mammogram, more towards doing colonoscopy. And that's where I think the primary care has a phenomenal advantage and a role versus high-end hospitals or emergency rooms, which cannot do that kind of care, which is ongoing, making sure you get your mammogram, making sure you get your vaccination. That's another huge preventive aspect which primary care practices provide is vaccination. So, if you think about all that aspects and you look at the model, let's say in Canada or model in UK, you would think that since we have more sophisticated procedures, expensive medications, access to Mayo Clinics and Cleveland Clinics of the world, our life expectancy, our infant mortality will be less. The answer is no. They have a model which is more driven by primary care, more by preventive care. In UK and Canada, their infant mortality is better than the United States. Their life expectancies are better both in men and women than the United States. And the reason is continuum of primary care, preventive care, population health. And that's where a place like Mahajan Medical Center is very well suited to help you with, so you don't end up in the ED with a heart attack, you don't end up in the ED with a stroke. Mm-hmm. So we need to do backward steps and work with your primary care, work with someone like Jen who does chronic care management, if you have any of those entities.
And I think that helps too, having someone to answer to, like having someone that calls you every month and checks on you, and that you actually have to say, okay, yes, I have changed my diet. Yes, you finally got through. And those are the cases that really speak to me.
Right. And that's what makes us keep coming back after 26 years that, we have Deborah, and she didn't say it, but I helped her quit smoking. So that's what makes you feel good about yourself too, the practice where you make a difference in someone's long-term outcomes, preventing strokes, preventing heart attack, preventing cancers by changing the lifestyle. You want to have a final word? Yeah.
One thing I will say, just for the years that I've been working with you guys, because there's other primaries in the area and I talk to a lot of members. You guys always answer the phone. Like, there's a recording when you answer, but you hit 0 and you get somebody that answers. And let me tell you, that does not exist anymore, I think, anywhere. I don't know that I've dealt with any other physicians, that actually you hit 0 and somebody answers. It's amazing. So that single-handedly alone is a huge benefit. So
when we were setting up a new office about 12 years ago, in this building, that's the first thing I tackled was, how to set up the prompts for the phone. And so my office manager at the time was saying, oh yeah, that's great. We got a fancy system and let them leave a message. I said, no. We got a geriatric practice. We got a senior practice. We need to give them an option where they hit 0 and they can bypass, and that's good for the younger generation. They like to leave messages. They like to use our patient portals, which is all, so it's good to give different tools. But for a senior population, geriatric population, which we are very privileged to have in our practice, I think it's very important to what you noted.
I think everybody hates the prompts. Maybe I'm geriatric, I guess, because so by the time I get to number 8, I'm like, wait a minute, what was number 1?
I know, right?
And then it's push 9 to hear it again. And this is just across the board with everything. So I really don't know of any other practice where you hit zero and somebody answers the phone. So it's awesome. And it's helpful because, again, if somebody's sick, they don't want to, or not feeling well and vomiting. I mean, you don't want to, wait for 2 minutes and then be on hold and then transferred somewhere. I mean,
Choose the wrong option.
oh God, don't choose the wrong option.
So let's summarize. We talked across the spectrum why it's important to call us first. Just remember that. Call us first. If it's not appropriate, as Jen said, we will direct you in the right, options. If you are in chronic care management or, you've been in the program where you have case manager assigned to you, you will have access to a phone number to call after hours, and Jen is one of the case manager. And they can contact me or whoever is on call, and we can help you even after hours. So we always have a provider on call for you. Try not asking for refills and that, so we get life to lead too. But other than that, if you're not sure it's a medical emergency or not, if it's office hours, no problem, walk in, we'll be more than happy to see you. But if it's after hours and you're a chronic care management patient or you've been assigned with our case manager, please call them. They're very knowledgeable. They have your records available 24/7, and they have access to the provider. So they can help you. Let's say you have a UTI, and they can help you get your antibiotics, and we can see you next day. So use that, and I think you'll be happier. With that, we come to the end of this show. I appreciate Jenny, I appreciate Jen, Deborah, and Kate, and behind the scenes, Denise, for making this show happen. Ciao.